This lecture is about the vascular diseases of the extremities. This will include the common diseases involving the peripheral arteries, veins, and the lymphatic system. Peripheral arterial disease. Atherosclerosis is the leading cause of occlusive arterial disease. It occurs in the 6th and 7th decades of life, and there is an increased prevalence of peripheral atherosclerotic disease in diabetes mellitus, hypercholesterolemia, hypertension, hyperhomocystinemia, and cigarette smokers. Atherosclerotic plaques are usually localized in the large and medium-sized arteries. The primary sites of involvement are abdominal aorta and iliac arteries in 30% of patients, femoral and popliteal arteries in 80 to 90% of patients, tibial and peroneal arteries in 40 to 50% of patients. The lesions occur preferentially at arterial branch points, sites of increased turbulence, altered shear stress, and intimal injury. Involvement of the distal vasculature is most common in elderly individuals and patients with diabetes mellitus. For the clinical manifestation, intermittent claudication is the most common symptom and is defined as a pain, ache, cramp, numbness, or a sense of fatigue in the muscles. It occurs during exercise and is relieved by rest. In severe arterial occlusive disease, there is rest pain or feeling of cold or numbness in the foot and toes. It usually occurs at night when the legs are horizontal and improves when the legs are in a dependent position. The site of location is distal to the occlusive lesion. For example, in aortoiliac disease, the symptoms are felt in the buttocks, hip, and thigh. In the femoral popliteal area, there is cuff claudication. Physical exam findings. There are decreased or absent pulses distal to the site of obstruction. There may be presence of bruit over the narrowed artery. You can see muscle atrophy, hair loss, thickened nails, smooth and shiny skin, and reduced skin temperature. In severe disorders, you can see pallor or cyanosis. Arterial ulcers or gangrene may also be present. When you elevate the legs and do repeated flexing of the calf muscles, it will produce pallor of the soles of the feet. You can also see rubor, secondary to reactive hyperemia, which may develop when the legs are in dependent position. Peripheral edema may also be present because they keep their legs in the dependent position most of the time. Ischemic neuritis can also be seen, resulting in numbness and hyporeflexion. Non-invasive testing for peripheral arterial disease. A good history and physical examination are usually sufficient. For objective assessment of the severity of the disease, you can request for digital pulse wave recordings, Doppler flow velocity waveform analysis, duplex ultrasonography, which involves B-mode imaging and pulse wave Doppler examination, segmental pressure measurements, transcutaneous oximetry, and stress testing. Ankle brachial index is a bedside maneuver that can determine the presence of peripheral arterial disease. It is the measurement of the blood pressure, primarily the systolic blood pressure in the brachial area as well as the ankle area. Normally, the ratio is 1. If it is less than 1, it indicates the presence of peripheral arterial disease, and less than 0.5 is consistent with severe ischemia. Treadmill testing can assess functional limitations objectively. It also allows simultaneous evaluation of the presence of coronary artery disease, and the finding of ischemic changes leads to the diagnosis of concomitant coronary artery disease. Contrast angiography should not be used for routine diagnostic testing, but is performed prior to potential revascularization. It is useful in defining the anatomy to assist in operative planning. It is also indicated if non-surgical interventions are being considered, such as percutaneous transluminal angioplasty or thrombolysis. Recent studies have suggested that magnetic resonance angiography has diagnostic accuracy comparable to that contrast angiography. For the prognosis, it is influenced primarily by the extent of coexisting coronary artery and cerebral vascular disease. Approximately one-half of patients with symptomatic peripheral arterial disease also have significant coronary artery disease. And patients with claudication have a 70% 5-year and a 50% 10-year survival rate. Deaths are either sudden or secondary to myocardial infarction. Approximately 75% of non-diabetic patients who present with mild to moderate claudication remain symptomatically stable or improved. Approximately 5% of the group ultimately undergoing amputation. Prognosis is worse in patients who continue to smoke cigarettes or who have uncontrolled diabetes mellitus. Supportive treatment measures. There should be meticulous care of the feet, which should be kept clean and protected against excessive drying with moisturizing creams. Patients should wear well-fitting and protective shoes, and they are advised to reduce trauma. Sandals and shoes made of synthetic materials that do not breathe should be avoided. Elastic support hose should be avoided as they reduce blood flow to the skin. Patients with ischemia at rest, there should be shock blocks under the head of the bed together with a canopy over the feet, and this will improve perfusion pressure and ameliorate some of the rest pain. The following measures are very important since controlling all the medical conditions may help resolve the pain or symptoms and also control the progression of the peripheral arterial disease. Patients should have lifestyle modification, especially discontinuing smoking and a good dietary control. Control blood pressure in hypertensive patients but to avoid hypotensive levels. Treatment of hypercholesterolemia has been shown to prevent or slow down the progression of the disease and also improves the survival in patients with coronary atherosclerosis. Supervised exercise training programs may improve muscle efficiency and prolong walking distance. Patients also should be advised to walk for 30 to 45 minutes daily, stopping at the onset of claudication and resting until the symptoms resolve before resuming ambulation. Pharmacologic management has not been as successful as the management of coronary artery disease. Vasodilators as a class have not proved to be beneficial. Drugs such as alpha-adrenergic blocking agents, calcium channel antagonists, papaverine, and other vasodilators have not been shown to be effective in patients with peripheral arterial disease. Pentoxifylline, a substituted xanthine derivative, decreases blood viscosity and also increases red cell flexibility, thereby increasing blood flow to the microcirculation, enhancing tissue oxygenation. This may increase the duration of exercise in patients with claudication. Cilostazol is a phosphodiesterase inhibitor with vasodilator and antiplatelet properties. It has been reported to increase claudication distance. Other drugs are being studied that potentially may improve coagulation, like L-arginine, which is a precursor of endothelium-dependent vasodilator musicoxide, and also vasodilator prostaglandins. Clinical trials with angiogenic growth factors such as vascular endothelial growth factor and basic fibroblast growth factors are proceeding, and they may promote collateral blood vessel growth in patients with critical limb ischemia. Aspirin and clopidogrel reduce the risk of adverse cardiovascular events in patients with peripheral arterial disease. They are very effective in prevention of acute myocardial infarction and stroke. Heparin and warfarin may be useful in acute arterial obstruction secondary to thrombosis or systemic embolism, but they are not effective in patients with chronic peripheral arterial disease. Thrombolytic interventions using drugs like streptokinase, urokinase, or recombinant tissue plasminogen activator may have a role in treatment of acute thrombotic arterial occlusion. Revascularization is reserved for patients with progressive, severe, or disabling symptoms and ischemia at rest, as well as for individuals who must be symptom-free because of their occupation. Non-operative interventions include percutaneous transluminal angioplasty with stent placement or atherectomy. 90 to 95% of iliac PTAs are initially successful. The 3-year patency rate is in excess of 75% and may be higher if a stent is placed in the iliac artery. The success rate for femoropopliteal PTA is approximately 80%, with a 60% 3-year patency rate. Patency rates are influenced by the severity of pretreatment stenosis, and the prognosis of total occlusive lesions is worse than that of non-occlusive stenotic lesions. Operative procedures for aortoiliac disease include aortobifemoral bypass, axillofemoral bypass, femoropefemoral bypass, and aortoiliac end arterectomy. Aortobifemoral bypass is the most frequently used procedure using knitted ductal grafts. Immediate graft patency approaches 99%. 5 and 10-year graft patency in survivors is in excess of 90 and 80% respectively. Operative complications include myocardial infarction and stroke, infection of the graft, peripheral embolization, and sexual dysfunction from interruption of autonomic nerves in the pelvis. Operative mortality ranges from 1 to 3%, mostly due to ischemic heart disease. Operative therapy for femoral popliteal artery disease includes in situ and reverse autogenous saphenous vein bypass grafts, placement of polytetrafluoroethylene or other synthetic grafts, and thromboend arterectomy. The operative mortality rate ranges from 1 to 3%. Long-term patency rate depends on the type of graft used, the location of the distal anastomosis, and the patency of runoff vessels beyond the anastomosis. Patency rates of femoropopliteal saphenous vein bypass grafts are 1 year approaching 90% and at 5 years 70 to 80%. The 5-year patency rates of infrapopliteal saphenous vein bypass grafts are 60 to 70%. The 5-year patency rates of infrapopliteal PTFE grafts are less than 30%. The high incidence of concomitant coronary artery disease leads to increased risk for cardiovascular complications like angina, prior myocardial infarction, ventricular ectopy, heart failure, or diabetes. Non-invasive tests such as treadmill testing, if feasible, dipyridamole thallium or sestamibi scintigraphy, dobutamine echocardiography, and ambulatory ischemia monitoring permit further stratification of patient risk. Cardiac catheterization should be considered in patients suspected of having left main or 3-vessel coronary artery disease. So we're done with peripheral artery disease. So the next topics are other arterial disorders. First is fibromuscular dysplasia. This is a hyperplastic disorder affecting medium-sized and small arteries occurring predominantly among females. They usually involve the renal and carotid arteries but can affect extremity vessels such as the iliac and subclavian arteries. You can see histological classification like intimal, medial, and periadventitial dysplasia. The medial dysplasia is the most common type and is characterized by hyperplasia of the media with or without fibrosis of the elastic membrane. In the angiography, you can see string of beads appearance caused by thickened fibromuscular ridges contiguous with thin, less involved portions of the arterial wall. Percutaneous transluminal angioplasty and surgical reconstructions have been beneficial in patients with debilitating symptoms or threatened limbs. Thromboangiitis obliterans or Buerger's disease. This is an inflammatory occlusive vascular disorder involving small and medium-sized arteries and veins in the distal upper and lower extremities. Cerebral, visceral, and coronary vessels may also be affected. Most frequent patients are men under the age of 40. Prevalence is high in Asians and individuals of Eastern European descent. The cause is not known, but there is a definite relationship to cigarette smoking in patients with this disorder. In the initial stage of Buerger's disease, polymorphonuclear leukocytes infiltrate the walls of the small and medium-sized arteries and veins. The internal elastic lamina is preserved and thrombus may develop in the vascular lumen. As the disease progresses, mononuclear cells, fibroblasts, and giant cells replace the neutrophils. In the later stage, it is characterized by perivascular fibrosis and recanalization. Clinical features include claudication of the affected extremity. This disorder primarily affects distal vessels, and usually symptoms are confined to the calves and feet, forearms, and hands. You can also see Raynaud's phenomenon and migratory superficial vein thrombophlebitis. Physical examination shows normal brachial and popliteal pulses, but reduced or absent phalangeal, ulnar, and or tibial pulses. Arteriography showed smooth, tapering segmental lesions in the distal vessels, and these are characteristic, as are collateral vessels at sites of vascular occlusion. Proximal atherosclerotic disease is usually absent. The diagnosis can be confirmed by excisional biopsy and pathologic examination of the involved vessel. There are no specific treatment except for smoking cessation. Prognosis is worse in individuals who continue to smoke. Arterial bypass of the larger vessels may be used in selected instances, as well as local debridement of wound, depending on the symptoms and severity of ischemia. Antibiotics may be useful. Anticoagulants and glucocorticoids are not helpful. If these measures fail, then amputation may be required. Acute arterial occlusion is a medical emergency. Urgent or emergent reperfusion is very important. This results in the sudden cessation of blood flow to an extremity. The severity of ischemia and the viability of the extremity depend on the location and extent of the occlusion, the presence and subsequent development of collateral blood flow. Two principal causes of acute arterial occlusions are embolism and thrombosis in situ. Most common sources of arterial emboli are the heart, aorta, and large arteries. They tend to lodge at vessel bifurcations. Emboli lodge most frequently in the femoral artery, followed by the iliac artery, aorta, popliteal, and tibio-peroneal arteries. Arterial thrombosis in situ occurs most frequently in atherosclerotic vessels at the site of stenosis or aneurysm and in arterial bypass grafts. Trauma also results in the formation of an acute arterial thrombus. This can complicate arterial punctures and placement of catheters. Less frequent causes include thoracic outlet compression syndrome, which causes the subclavian artery occlusion and entrapment of the popliteal artery by abnormal placement of the medial head of the gastrocnemius muscle. Polycythemia and hypercoagulable disorders are also associated with acute arterial thrombosis. The clinical features of acute limb ischemia depend on the location, duration, and severity of the obstruction. There can be severe pain, paresthesia, numbness, and coldness develop in the involved extremity within 1 hour. Paralysis may occur with severe and persistent ischemia. On physical exam, there are loss of pulses distal to the occlusion, cyanosis or pallor, mottling, decreased skin temperature, muscle stiffening, loss of sensation, weakness, and or absent deep tendon reflexes. In the presence of an adequate collateral circulation, the symptoms and findings may be less impressive. Arteriography is useful for confirming the diagnosis and demonstrating the location and extent of the occlusion. Treatment of acute limb ischemia includes administration of intravenous heparin to prevent propagation of the clot. In cases of severe ischemia of recent onset, immediate intervention to ensure reperfusion is indicated. Surgical thromboembolectomy or arterial bypass procedures is sometimes indicated. Intraarterial thrombolytic therapy is effective when acute arterial occlusion is caused by a thrombus in an atherosclerotic vessel or arterial bypass graft. It may also be indicated when the patient's overall condition contraindicates surgical intervention or when smaller distal vessels are occluded. You can use intraarterial urokinase or intraarterial recombinant RTPA. If the limb is not in jeopardy, a more conservative approach that includes observation and administration of anticoagulants may be taken. Anticoagulation prevents recurrent embolism and reduces the likelihood of thrombus propagation. IV heparin sometimes is followed by oral warfarin. Emboli resulting from infectious endocarditis, the presence of prosthetic heart valves, or atrial myxoma often require surgical intervention to remove the cause. Atheroembolism. Small deposits of fibrin, platelet, and cholesterol debris embolize from proximal atherosclerotic lesions or aneurysmal sites. The emboli tend to lodge in the small vessels of the muscle and skin and may not occlude the large vessels. Distal pulses usually remain palpable. This will result in ischemia and the blue toe syndrome. You can see digital necrosis and gangrene, localized areas of tenderness, pallor, and libido reticularis occur at sites of emboli. This is how a blue toe syndrome will look like. Note that there are discoloration in the big toe, fourth, and fifth digits. So, in the management of blue toe syndrome, skin or muscle biopsy may demonstrate cholesterol crystals. It is notoriously difficult to treat. Neither surgical revascularization procedures nor thrombolytic therapy is helpful because of the multiplicity, composition, and distal location of the emboli. There is some evidence suggests that platelet inhibitors prevent arterioembolism. Surgical intervention to remove or bypass the atherosclerotic vessel or aneurysm that cause the recurrent arterioemboli may be necessary. Thoracic outlet compression syndrome can be diagnosed using the following maneuvers: costoclavicular maneuver, which is posterior rotation of the shoulders; hyperabduction maneuver, which is raising the arm to 180 degrees; chest x-ray will indicate the presence of cervical ribs; electromyogram is abnormal if the brachial plexus is involved. Treatment is conservative. Advised to avoid the positions that cause symptoms. Patients also benefit from shoulder girdle exercises. Surgical procedures is sometimes indicated. Removal of the first rib or resection of the scalenus anticus muscles are necessary occasionally for relief of symptoms or treatment of ischemia. Arteriovenous fistula are abnormal communications between an artery and a vein, bypassing the capillary bed, and this may be congenital or acquired. The clinical features depend on the location and size of the fistula. On physical exam, a pulsatile mass is palpable, and a thrill and bruit lasting throughout the systole and diastole are present over the fistula. The clinical manifestation of chronic venous insufficiency, including peripheral edema, large tortuous varicose veins, and stasis pigmentation, become apparent because of the high venous pressure. Evidence of ischemia may occur in the distal portion of the extremity. Skin temperature is higher over the arteriovenous fistula. Large arteriovenous fistulas may result in increased cardiac output with consequent cardiomegaly and high output heart failure. Arteriovenous fistulas are often evident from the physical examination. Nicola-Doni-Branham sign is the reflex slowing of the heart rate when you compress the AV fistula. Arteriography can confirm the diagnosis and is useful in demonstrating the site and size of the AV fistula. Treatment: you can do surgery, radiotherapy, or embolization. Many of these lesions are best treated conservatively using elastic support hose to reduce the consequences of venous hypertension. Embolization with autologous material such as fat or muscle, or with hemostatic agents such as gelatin sponges or silicone spheres, is useful to obliterate the fistula. Acquired arteriovenous fistulas are usually amenable to surgical treatment that involves division or excision of the fistula. Raynaud's phenomenon. This is characterized by episodic digital ischemia, manifested clinically by the sequential development of digital blanching, cyanosis, and rubor of the fingers or toes following cold exposure and subsequent rewarming. Emotional stress may also precipitate Raynaud's phenomenon. During the ischemic phase, blanching or pallor is due to vasospasm of digital arteries. The capillaries and venules dilate, and cyanosis results from the deoxygenated blood that is present in these vessels. Sensation of cold, numbness, or paresthesia of the digits often accompany the phase of pallor and cyanosis. Reactive hyperemia is seen with rewarming, and this is when the digital vasospasm resolves and blood flow into the dilated arterioles and capillaries increases dramatically. This will impart a bright red color to the digits. The pathophysiology of Raynaud's phenomenon is secondary to exaggerated reflux sympathetic vasoconstriction. This is also supported by the fact that Alpha-adrenergic blocking agents as well as sympathectomy decrease the frequency and severity of Raynaud's phenomenon. The phenomenon is broadly categorized into two. Raynaud's disease is due to idiopathic cause, and the secondary variety is associated with other disease states or known causes of vasospasm. So this table is a more specific category of the classification of Raynaud's phenomenon. Primary or idiopathic Raynaud's phenomenon is called Raynaud's disease. Secondary Raynaud's phenomenon are either due to collagen vascular diseases, arterial occlusive diseases, pulmonary hypertension, neurologic disorders, blood dyscrasias, trauma, and drugs. Raynaud's disease is diagnosed when secondary causes of Raynaud's phenomenon have been excluded. Over 50% of patients with Raynaud's phenomenon have Raynaud's disease. Women are affected about 5 times more often than men, and the age of presentation is usually between 20 and 40 years. Fingers are involved more frequently than the toes, and the toes are affected in 40% of the patients. Rarely, the earlobes and the tip of the nose are involved. It also occurs frequently in patients who have migraine headaches or variant angina. The physical exam often are entirely normal. Fingers and toes may be cool between attacks and may perspire excessively. Thickening and tightening of the digital subcutaneous tissue or sclerodactyly develop in 10% of patients. In general, patients with Raynaud's disease appear to have a milder form of Raynaud's phenomenon. Fewer than 1% of these patients lose a part of a digit. The disease improves spontaneously in approximately 15% of patients and progresses in about 30%. Secondary causes of Raynaud's phenomenon occurs in 80 to 90% of patients with systemic sclerosis or scleroderma, about 20% of patients with SLE, 30% of patients with dermatomyositis or polymyositis. They also frequently develop in patients with rheumatoid arthritis. Atherosclerosis of the extremity is a frequent cause. They also occur in patients with primary pulmonary hypertension and a variety of blood dyscrasias like cold agglutinin, cryoglobulinemia, or cryofibrinogenemia. Other secondary causes of Raynaud's phenomenon include hyperviscosity syndromes that accompany myeloproliferative disorders and Waldenstrom's macroglobulinemia. It also occurs in patients whose vocations require the use of vibrating tools like chainsaws or jackhammers. Also increase in pianists and typists. Electric shock injury to the hands or frostbite may lead to the later development of Raynaud's phenomenon. Drugs also can lead to Raynaud's phenomenon, like ergot preparation, methylsergide, beta blockers, and chemotherapeutic agents. For the treatment, most patients experience only mild and infrequent episodes and only needs assurance, and they should be instructed to dress warmly and avoid unnecessary cold exposure. Tobacco use is contraindicated. Drug treatment is only reserved for severe cases. We can use calcium channel antagonists, especially nifedipine and diltiazem, and these agents decrease the frequency and severity of Raynaud's phenomenon. Adrenergic blocking agents like reserpine have been shown to increase nutritional blood flow to the fingers. Postsynaptic alpha-1 adrenergic antagonists like prazosin has been used with favorable responses. Doxazosin and terazosin may also be effective. Other sympatholytic agents like methyl-dopa, guanethidine, and phenoxybenzamine may also be useful in some patients. Surgical sympathectomy is helpful in some patients who are unresponsive to medical therapy, but benefit is often transient. In acrocyanosis, there is arterial vasoconstriction and secondary dilatation of the capillaries and venules, and resulting to persistent cyanosis of the hands and less frequently the feet. The cyanosis may be intensified by exposure to cold environment. Women are affected more frequently than men, and the age of onset is usually less than 30 years old. Generally, patients are asymptomatic but seek medical attention because of the discoloration. This is distinguished from Raynaud's phenomenon by the persistent and not episodic discoloration of the extremity, and this discoloration extends proximally from the digits and blanching does not occur. Treatment is only reassurance and advise the patient to dress warmly and avoiding cold exposure. In livedo reticularis, localized areas of the extremities develop a mottled or net-like appearance of reddish to blue discoloration. They may be more prominent following cold exposure. Idiopathic form of this disorder occurs equally in men and women. The age of onset is in the third decade. They are usually asymptomatic and seek attention for cosmetic reasons. They can also occur following atherosclerosis. PERNIO, or chilblains, is a vasculitic disorder associated with exposure to cold. You can see raised erythematous lesions develop on the lower part of the legs and feet in cold weather. It is associated with pruritus and burning sensation, and they may blister and ulcerate. In pathologic exam, you can see angiitis characterized by intimal proliferation and perivascular infiltration of mononuclear and polymorphonuclear leukocytes. Giant cells may be present in the subcutaneous tissue. Management is avoid exposure to cold, and ulcers should be kept clean and protected with sterile dressing. Sympatholytic drugs may be effective in some patients. Erythromelalgia is characterized by burning pain and erythema of the extremities. The feet are involved more frequently than the hands. Males are affected more frequently than females. They may occur at any age, but is most common in the middle age. They may be primary or secondary to myeloproliferative disorders like polycythemia vera and essential thrombocytosis, or it may occur as an adverse effect of a drug like nifedipine or bromocriptine. Patients usually complain of burning in the extremities that is precipitated by exposure to warm environment and aggravated by dependent position. The symptoms are relieved by exposing the affected area to cool air or water or by elevation. This is distinguished from ischemia, secondary to peripheral arterial disorders, and peripheral neuropathy because the peripheral pulses are present and neurologic exam is normal. There is no specific treatment. Aspirin may produce relief in patients with erythromelalgia secondary to myeloproliferative disorders. Treatment of associated disorders in secondary erythromelalgia may be helpful. In frostbite, there is tissue damage resulting from severe environmental cold exposure or from direct contact with a very cold object. The injury results from both freezing and vasoconstriction. It usually affects the distal aspects of the extremities or exposed parts of the face like the ears, nose, chin, and cheeks. Patient can feel pain or paresthesia, and the skin appears white and waxy. On rewarming, there is cyanosis and erythema. Also, a wheal and flare formation can also be seen, edema, and superficial blisters. Deep frostbite involves muscles, nerves, and deeper blood vessels. It may result in edema of the hand or foot. Vesicles and bulla may form. You can also see tissue necrosis and gangrene. The initial treatment for frostbite is rewarming. This is accomplished by immersion of the affected part of the body in water bath at temperatures between 40 to 44 degrees centigrade. Massage, application of ice water, and extreme heat are contraindicated. The area should be cleansed with soap or antiseptic, and sterile dressings are applied. Analgesics are often required during rewarming. Antibiotics are used if there is evidence of infection. The efficacy of sympathetic blocking drugs is not established. Following recovery, the affected extremity may exhibit increased sensitivity to cold. This slide is just something to show you the different pictures of the arterial disorders. Letter A is Raynaud's phenomenon, where you can see pallor of the digits or the fingers. Letter B is acrocyanosis. If you will look at the difference of A and B, there is a marked difference in the color of the fingers. Letter C is livedo reticularis, where you can see cyanosis of distal parts of the finger and mottling of the hands. Letter D is PERNIO, where you can see skin lesions in the plantar aspects of the digits. Letter E is erythromelalgia, and letter F is frostbite. So we will now talk about venous disorders. First is venous thrombosis. The presence of thrombus within a superficial or deep vein is termed venous thrombosis. And if there is accompanying inflammatory response, it is called thrombophlebitis. Vircho's triad, these are factors that predispose to venous thrombosis. First is stasis, the presence of vascular damage, and hypercoagulability. So this is a table showing the conditions associated with an increased risk for the development of venous thrombosis. Surgery, primarily orthopedic surgery, cancer or neoplasms, trauma, immobilization, pregnancy, use of estrogen, either for contraception or for hormonal replacement treatment, hypercoagulable states, venulitis, and prior deep venous thrombosis. Venous thrombosis may occur in more than 50% of patients having orthopedic surgical procedures, particularly those involving the hip or the knee. 10 to 40% of patients who undergo abdominal or thoracic operations may likewise also lead to venous thrombosis. The prevalence is particularly high in patients with cancer of the pancreas, lungs, genitourinary tract, the stomach, and the breast. Approximately 10 to 20% of patients with idiopathic deep venous thrombosis have or develop clinically overt cancer. Immobilization is a major predisposing cause of venous thrombosis. The most important consequences of DVT are pulmonary embolism and syndrome of chronic venous insufficiency. DVT of the iliac, femoral, or popliteal veins is diagnosed when there is unilateral leg swelling, warmth, and erythema. Tenderness may be present along the course of the involved veins, and a cord may be palpable. There may be increased tissue turgor, distension of superficial veins, and appearance of prominent venous collaterals. Deoxygenated hemoglobin in stagnant veins imparts a cyanotic hue to the limb, a condition called phlegmatia cerulea dolens. In markedly edematous legs, the interstitial tissue pressure may exceed the capillary perfusion pressure, causing pallor, a condition designated phlegmatia alba dolens. In deep venous thrombosis of the calf veins, the most common complaint is pain in the calf area. Physical exam may reveal posterior calf tenderness, warmth, increased tissue trigger, or modest swelling, and rarely you may feel a cord-like structure. Common sign is increased resistance or pain during dorsiflexion of the foot, but this is an unreliable diagnostic sign. In deep venous thrombosis of the upper extremity, the incidence is increasing because of greater utilization of indwelling central venous catheter. So how do you diagnose DVT? You can use duplex venous ultrasonography using the B mode, like 2D imaging and pulse wave Doppler interrogation. A thrombus can be detected either by direct visualization or by inference when the veins does not collapse on compressive maneuvers. This modality also measures the velocity of flow in the veins. The positive predictive value of duplex venous ultrasound approaches 95% for proximal DVT. In the calf, because calf veins are more difficult to visualize than proximal veins, the sensitivity is around 50 to 75%, although specificity is quite high at 95%. Other modalities in the diagnosis of DVT: impedance plethysmography. This measures changes in venous capacitance during physiologic maneuvers. The predictive value of this test for detecting occlusive thrombin in proximal veins is approximately 90%. But this is less sensitive for diagnosing DVT of the calf. Magnetic resonance imaging is also used. The accuracy for assessing proximal DVT is similar to that of duplex, and this is useful in patients with suspected thrombosis of the superior and inferior vena cava or the pelvic veins. Venography: contrast medium is injected into a superficial vein of the foot and directed to the deep system by the application of tourniquets. Presence of filling defect or absence of filling of the deep veins is required to make the diagnosis. So for treatment of DVT, anticoagulation prevents thrombus propagation and allows the endogenous lytic system to operate to lyse the clot. You can use unfractionated heparin with an initial bolus of 7,500 to 10,000 units, followed by a continuous infusion of 1,000 to 1,500 units per hour. Partial thromboplastin time should be tested, and the ideal result should be approximately twice the control value. In fewer than 5% of patients, heparin therapy may cause thrombocytopenia, and infrequently these patients develop arterial thrombosis and ischemia. Low molecular weight heparins are reported to be as effective or may even be better than the conventional unfractionated heparin in preventing extension or recurrence of venous thrombosis. You can give enoxaparin at a dose of 1 mg per kilogram given subcutaneously twice daily. The incidence of thrombocytopenia is less with low molecular weight heparins than with unfractionated heparin. Hirudin, which is a direct thrombin inhibitor, can also be given for patients in whom heparin is contraindicated because of heparin-induced thrombocytopenia. Warfarin, at a dose to be adjusted to maintain the INR of 2 to 3, can also be given. For patients with proximal DVT, anticoagulation is indicated since pulmonary embolism may occur in approximately 50% of untreated individuals. Anticoagulation for isolated DVT of the calf is controversial. However, 20 to 30% of calf thrombi propagate to the thigh, thereby increasing the risk of pulmonary embolism. So I suggest starting anticoagulation also in these subsets of patients. The overall incidence of pulmonary embolism in patients presenting initially with deep cough-bait thrombosis is 5 to 20%. Anticoagulant treatment should be continued for at least 3 to 6 months for patients with acute idiopathic DVT and for those with temporary risk factor for venous thrombosis to decrease the chance of recurrence. Anticoagulation is indefinite for patients with recurrent DVT and for those in whom associated causes such as malignancy or hypercoagulability have not been eliminated. IBC filter can be inserted if anticoagulation is contraindicated or because there is bleeding diathesis or there is a risk of hemorrhage. This filter will prevent the pulmonary embolism. Thrombolytic or fibrinolytic agent. There is no evidence that this treatment is more effective than anticoagulants in preventing pulmonary embolism. These drugs may accelerate clot lysis, preserve venous valves, and decrease the potential for developing post-phlebitic syndrome. So how do you prevent DVT? In clinical situations where the risk of DVT is high, you can use low-dose unfractionated heparin, 5,000 units 2 hours prior to surgery, and 5,000 units every 8 to 12 hours post-operatively. Warfarin can also be used, external pneumatic compression. Low molecular weight heparins are said to be more effective than conventional heparin and to cause an equal or lower incidence of bleeding. So furthermore, in preventing DVT, the naparoid, a low molecular weight heparinoid, may be used for prophylaxis in patients undergoing hip surgery. Warfarin with a PTPA INR of 2 to 3 is effective in preventing DVT associated with bone fractures and orthopedic surgery. External pneumatic compression devices is also used if anticoagulation might cause serious bleeding, as well as during neurosurgery or transurethral resection of the prostate. New medicine like NOAC or novel anticoagulant are also being used currently. Superficial vein thrombosis. These are thrombosis of the greater or lesser saphenous veins or their tributaries. It does not result in pulmonary embolism. This is usually associated with intravenous catheters and infusions. They also occur in varicose veins. They may develop in association with deep venous thrombosis. Migrating superficial vein thrombosis is often a marker for a carcinoma. They may also present in patients with vasculitis such as thromboangiitis obliterans. Treatment is primarily supportive. Bed rest with elevation of the legs and application of warm compresses may help. NSAIDs may provide analgesia, but may also obscure the clinical evidence of thrombus propagation. Varicose veins are dilated, tortuous superficial veins. They result from defective structure and function of the valves of the saphenous veins, from intrinsic weakness of the vein wall, from high intraluminal pressure, rarely from AV fistulas. Primary varicose veins originate in the superficial system. They are 2 to 3 times as frequently in women as in men. Half of patients have family history of varicose veins. Secondary varicose veins results from deep venous insufficiency and incompetent perforating veins, or from deep venous occlusion causing enlargement of superficial veins that are serving as collaterals. Patients with varicose veins feel ache or pressure sensation in the legs after prolonged standing. It is relieved with leg elevation. The leg feels heavy and you can see mild ankle edema occasionally. Rarely, varicosity ruptures and bleeds, resulting to skin ulcerations near the ankle. And these are just treated with conservative measures. Symptoms often decrease when the legs are elevated periodically, when prolonged standing is avoided, and when elastic supports, hose, or stockings are worn. Patients are usually advised wearing external compression stockings to alleviate the symptoms. Sometimes, sclerotherapy can also be done when there are small symptomatic varicose veins. This is a picture of a patient with venous insufficiency developing active venous ulcer near the medial malleolus. Try to differentiate this with arterial ulcers. Surgery involves extensive ligation and stripping of the greater and lesser saphenous veins. This treatment is reserved for patients who are very symptomatic, suffer recurrent superficial vein thrombosis, or they develop skin ulceration. They may also be indicated for cosmetic reasons. Chronic venous insufficiency. This may result from deep venous thrombosis and/or valvular incompetence. Patients often complain of a dull ache in the leg that worsens with prolonged standing and results with leg elevation. On physical exam, you can see increased leg circumference, peripheral edema, and superficial varicose veins. Erythema, dermatitis, and hyperpigmentation develop along the distal aspect of the leg. Skin ulceration may occur near the medial and lateral malleolus, and cellulitis may be a recurring problem. This is the CAAP classification that will guide us in the diagnosis and treatment of venous insufficiency. C is a clinical classification wherein C0 is the most benign when there are no visible or palpable sign of venous disease, and C6 is the most serious when you can see active venous ulcers. Etiology classification can be congenital, primary, secondary, or post-thrombotic, or if you cannot see anything, then EN, no venous etiology identified. For anatomic classification, it can be superficial, perforator veins, deep veins, or no venous location identified. For the pathophysiologic classification, it can be due to reflux, obstruction, combination of the two, or no venous pathophysiology identifiable. So, abnormalities of the lymphatic system. The lymphatic circulation is involved in the absorption of interstitial fluid and in response to the infection. The prevalence of primary lymphedema is approximately 1 in 10,000 individuals. This table shows the causes of lymphedema. It can be primary, either sporadic when there is no identifiable cause, due to genetic disorders, due to chromosomal aneuploidy, and other disorders associated with primary lymphedema. It can also be secondary due to infection, neoplasm, post-surgery or irradiation of the axillary or inguinal lymph nodes for the treatment of cancer. It can be iatrogenic or miscellaneous. Primary lymphedema, it is secondary to agenesis, hypoplasia, or obstruction of the lymphatic vessels. They may be associated with Turner syndrome, Klinefelter syndrome, Noonan syndrome, the yellow nail syndrome, the intestinal lymphangiectasia syndrome, and lymphangiomyomatosis. Women are affected more frequently than men. There are 3 clinical subtypes: congenital lymphedema or Milroy's disease, which appears shortly after birth, lymphedema precox or Meiggs disease, which is at the onset at the time of puberty, lymphedema tarda, and these are usually begins after age 35. Secondary lymphedema results from damage or obstruction of previously normal lymphatic channels. Filariasis is the most common cause of secondary lymphedema. Generally, this is a painless condition, but patients may experience a chronic, dull, heavy sensation in the leg, and most often they are concerned about the appearance of the leg. This gradually progresses up to the leg so that the entire limb becomes edematous. Evaluation should include diagnostic studies to clarify the cause. Abdominal and pelvic ultrasound and computed tomography can be used to detect obstructing lesions such as neoplasm. MRI may reveal edema in the epiphyseal compartment and identify lymph nodes and enlarged lymphatic channels. Lymphoscintigraphy and lymphangiography are rarely indicated, but they can be used to confirm the diagnosis or to differentiate primary from secondary lymphedema. In primary lymphedema, the lymphatic channels are absent, hypoplastic, or ectatic. In secondary lymphedema, lymphatic channels are usually dilated, or it may be possible to determine the level of obstruction. These are pictures of lymphedema. The one on the left is characterized by swelling of the leg, non-pitting edema, and squaring of the toes. The one on the right is an advanced chronic stage of lymphedema, illustrating the woody appearance of the leg with acanthosis and verrucous overgrowth. For the treatment, patients must be instructed to take meticulous care of their feet to prevent recurrent lymphangitis. Skin hygiene is important, and emollients can be used to prevent drying. Prophylactic antibiotics are often helpful. Patients should be encouraged to participate in physical activity. Frequent leg elevation can reduce the amount of edema. Physical therapy can facilitate lymphatic drainage. Graduated compression hose or stacking to reduce the amount of lymphedema that develops with upright procedure can also be used. Do not use diuretics. Recently, microsurgical lymphaticovenous anastomotic procedures have been performed to rechannel the lymph flow from obstructed lymphatic vessels into the venous system. This is the end of lecture. This lecture is just a guide for you. Please read your reference Harrison for more specific discussion of the problems of the peripheral vascular system. Thank you.